Okay, now we're going into the systems-based assessment and plan or common things you'll encounter on the general surgery and trauma services at your hospital, and we'll go by systems-based. Usually neuro, we talk about pain. So common pain regimens that you can give for your patients are, we'll usually at our institution do it based on a pain scale. So an example would be on a pain scale of 1 to 3, Tylenol, 1000 milligrams, Q4 hours as needed. And then if there's pain is between 4 to 6, you can give something like Percocet, 5 milligrams, Q4 hours PRN. And if their pain is 7 to 10, you can give Percocet 10s, Q4 hours PRN. And anything for breakthrough, you can give, options are morphine and Dilaudid. Dilaudid, a adequate dose. You want to start low and then go high as you need would be 0.5 milligrams IV every 3 hours PRN for breakthrough, which means when their pain is above a 10 and nothing is cutting it. And then you can also, morphine, remember, so you have to know the conversion. So 1 milligram of Dilaudid is equal to 7 milligrams of morphine. Other adjuncts that you can use, multimodal pain control is becoming quite popular now. So other adjuncts are muscle relaxers, Robaxin, 750 milligrams every 6 hours. You can also prescribe tramadol instead of Percocet, 50 milligrams every 6 hours as needed. For neuropathic pain, we can also use gabapentin, 300 milligrams TID. These are also good adjuncts to use, but as a kind of safe starting point, the Tylenol, Percocet, Dilaudid regimen is a pretty safe bet. But one thing to be cautioned about is blood pressure, also causing somnolence, especially in the geriatric population. You want to be more cautious with the opioids you're prescribing these patients, as opioids can precipitate histamine release and subsequent hypotension, as well as these older patients who are on multiple medications, their sleep wake cycle is altered. You can definitely increase their risk of hospital-based delirium. So be cautioned with when you're prescribing these medications. Another thing is delirium. So especially in this geriatric population, something you'll notice a lot is that hospital-based delirium is a real thing. Like I said, they're not in their regular environment that they're used to being in. Their sleep-wake cycles are altered. Also, being in the hospital, you have a lot of different people visiting you multiple times a day. It's very difficult to get a nice 8-hour sleep uninterrupted. You have your nurse techs coming in getting blood pressures, you have your phlebotomist drawing blood, you have people from your x-ray techs coming in and taking chest x-rays, KUBs, you have the nurses coming in giving medications, giving DVT prophylaxis shots, you have the residents rounding on them, you have the attendings rounding, and it becomes very tiresome. Remember that delirium is a real thing and you want to treat it with frequent reorientation, reminding them where they are, what the month, the day, the year is, what they're here for, and encouraging them to take cat naps throughout the day. But remember that hospital-based delirium, as common as it is, it's a diagnosis of exclusion. So you want to rule out the other things first before you diagnose it as delirium. So remember, you want to rule out medical causes like oxygen. So if they're hypoxic, their SATs are dropping, this can cause delirium. Make sure you rule that out. You want to look at their electrolytes, making sure that if there is a new onset delirium, to order a fresh CMP or BMP to make sure that there aren't any electrolyte abnormalities. You want to rule out infection. Patients who are starting to become infected will also have symptoms similar to delirium. After you've ruled out the medical causes, then you can diagnose it as delirium, but in slang in the hospital, we'll also call it sundowning. And then again, frequent reorientation, minimal disturbances. Altered mental status. Anytime a patient has an acute change in mental status, usually a good way is the alert, and we usually go alert and oriented times 4. Are they alert into person, place, time, and situation. Has there been a change in that? If there is, you want to make sure that you rule out all the medical causes first. You want to, as the intern on the floor, get the nurse tech to get a fresh set of vitals, get fresh set of labs. You want to do a full neurological exam, cranial nerves 2 to 12. You want to check their sensation, their motor, assess if they're alert and oriented, and also if they're, and in your exam there's concern, then you want to bump it up the chain. Notify your PGY2, your PGY3, whoever is your senior on that service, let them know so that they can try to help you and think about things that you may have missed. But as an intern, before you run it up the chain, make sure that you've thought about it and that you've ordered the necessary workup so that they have something to work off. Sundowning, oftentimes frequent reorientation may not work and you may have to resort to pharmacological methods. And so common things that we can use are Haldol. So 5 milligrams of IV Haldol should generally do the trick. If they're smaller or older, then you want to use a lower dose. Other medications that we can use on the geriatric population is Seroquel. At my institution, we have quite a large geriatric population, so we often use Seroquel 25 milligrams QHS PRN for sundowning or agitation. Insomnia is another common situation that you'll find on the floor. So make sure that if they do have insomnia, that you've restarted their home medications that they've been on. If they're younger, below 60 years old, Benadryl is a good option, 25 milligrams or 50 milligrams if it's not cutting it. But then if your hospital has melatonin, that works too. Trazodone is also another good option but trazodone is generally the safest medication for insomnia in the elderly. Patients who are alcoholic, ETOH abuse, you want to make sure in your order set that you have the CWA protocol ordered so that the nurses can assess their CWA score for withdrawals and give them benzodiazepines as needed. Little pearl here, oftentimes we will order a CWA assessment but will not give PRN benzos. Be wary of patients, especially elderly ones, who have been on long-term benzodiazepines for many years. The textbooks teach you that benzodiazepines are a contraindication to use in the elderly, but remember that if the elderly patient has been on it chronically for many years, then it generally is safer to restart them on that to minimize the risk of withdrawal. Remember that withdrawal from alcohol or benzodiazepines can kill you. So if the patient has been taking it for many years, then it's worth it to just restart it. Nausea and vomiting is also very common in the hospital population. If you get a call from a nurse and they're saying that the patient is nauseous and vomiting, the first thing you want to do always is assess the patient, because there could be many different potential causes for nausea and vomiting. So you want to look at them yourselves and also make sure that they're able to protect their airway and not at risk for aspiration. Once you've assessed the patient, they have nausea, then common medication that you can give is 4 milligrams IV Zofran every 4 hours as needed. Cardiovascular. A lot of patients at my institution, especially with the geriatric population that's been increasing more, atrial fibrillation is a common comorbidity. So you're going to have to get used to treating RVR, which is rapid ventricular response. It's anything greater than 110. So there was something called the RACE-2 trial and the AFFIRM trial, and they showed that medications that suppress the heart rate versus antiarrhythmic are superior in AFib, and also the target heart rate should be less than 110. So anytime a patient's heart rate is greater than 110, then this is considered rapid ventricular response. You want to have them rate controlled under 110. And so a common starting algorithm you can start with is if you get a call that the patient who has a history of AFib, remember, a new onset AFib, that's different. If there's a new onset AFib, you have to start thinking about other potential causes of an arrhythmia, like a myocardial infarction. But if they have a history of AFib and now they're no longer rate controlled, first you want to assess, is this pain related? Because a lot of time post-surgical patients may have pain. Way to tell that is to ask the patient and also check their vital. If they're hypertensive and tachycardic, then oftentimes, that's pain. So you may be able to rate control them by adequately treating their pain. What if they're not hypertensive, but they're in RVR and they're not in any pain? Well, in that case, then a common algorithm to get the patient rate controlled is to give 5 milligrams of IV metoprolol every 5 minutes for a total of 3 doses. So 5 milligrams, wait 5 minutes, give another 5 if it's not rate controlled, wait 5 minutes, give another 5. If they're still not rate controlled after that, you can give diltiazem IV. And for a diltiazem IV push, it's usually weight based. Your hospital should have it, or a flat number is 10 milligrams IV of diltiazem. Give it once. And if they're still not rate controlled, after 10 minutes, then that's when you want to consider your refractory lines of treatment, which is you can either do a diltiazem drip or to an amiodarone drip. Remember that in terms of diltiazem, it's a calcium channel blocker, just like a beta blocker. You want to be careful. A relative contraindication is hypotension. So remember that. Keep in the back of your mind that these medications can drop your patient's blood pressure. So beware of that. Amiodarone is an antiarrhythmic. It can be used as a drip, but be wary. Once you start hitting over 10, usually the number is 10 grams. Once the patient has received over 10 grams of amiodarone, then they're at risk for all the side effects from that. Remember the mnemonic PFTs, TFTs, LFTs? It can cause pulmonary fibrosis, it can cause thyroid abnormalities, and it can also cause transaminitis. So usually at that point, if everything's refractory, you should also be running this up the chain as the patient. If they're unable to be rate controlled on the floor, they may need to go down to the ICU. Again, another thing too, I forgot to say, but when someone's in AFib with RVR, you want to first rule out reversible causes. So if a patient has AFib, anything that can cause tachycardia can kick them into AFib with RVR. So think about, pain. Think about fluid status, right? What if their volume down? Then they'll be slightly hypotensive and tachycardic. That could cause them RVR. Maybe they need fluid. Decreased oxygen, hypoxia, low O2 sets can also cause patients to go into RVR to increase delivery of oxygen. Also, fluid overload. If a patient is very fluid up, if they have CHF, the stretching of the atrium can distort the electrical conduction of the atrium and causing the patient to go into AFib with RVR. Another situation you should be aware of is patients with congestive heart failure. When they have a history of congestive heart failure, you want to find out when their last echocardiogram was. What is their ejection fraction? Is it reduced or is it preserved? With patients in CHF, you want to be very careful with IV fluids. A general safe starting point. So remember, IV fluids is a good rule is kilograms that they weigh plus 40. That's your maintenance rate. So, a 70 kilogram male, healthy, their maintenance rate is 110, right? But in CHF patients and also CKD patients, because CHF patients can go into congestive heart failure very quickly with increased volume, and CKD patients do too as well due to decreased diuresis. But with these type of patients, you want to be cautious, and a good starting point is whatever the maintenance dose is, cut it in half. So if it's 110, then you can start off with 55. If a patient is tachycardic, the first thing you want to do is look at their trends. Have they been tachycardic the whole time? Is this something new? Because if something new, that's something that you want to be more concerned for. But you always want to rule out the dangerous things first. So rule out MI, pulmonary embolism. Start thinking about pain. Are they in pain? You want to treat the root cause for the tachycardia. Oftentimes you'll see that, people who practice medicine the wrong way will just treat the numbers. They'll give metoprolol for tachycardia, but as a strong surgical resident, you want to treat the root cause. Hypotension. You have to look at the trends. Look at their baseline blood pressure. Some patients are very small and they may live in this, low 90s. That may be their baseline. So look at their trends. If it's a sudden drop, then yes, treat it like hypotension, and you want to give them IV fluids, a liter bolus. to start. But anytime there's any concern for hypotension, you should be looking and notifying your senior on the service. Patient has chest pain. First things first, examine the patient. Find out what type of chest pain is this. Does this seem like cardiac angina, or is this more like costochondritis? Is it reproducible pain? Can they touch it with one finger? If it is, then most likely that's musculoskeletal. But if it's a crushing chest pain, then you should be concerned for something like, potential MI. And also remember that elderly patients may present atypically. They may have epigastric pain instead, or problems with breathing. So anytime your red flag comes off that this may be cardiac, or if that's a differential, then that's when you want to order your stat EKG, your labs, and your chest x-ray. Hypertension. Again, in the surgical population, you want to rule out pain. Ask about their baseline. Trends and baselines are so important for making decisions. If they have a history of hypertension, make sure you've restarted their home meds. And again, remember, generally perioperative, we hold ACEs and ARBs due to increased risk for perioperative AKI, and we can supplement that with PRNs. So common PRNs you may see in the hospital are hydralazine, 10 milligrams IV every 4 hours, PRN for SBP greater than, depends on the attending or your institution, can be set at above 160 or 170. Remember, hydralazine is a vasodilator, so it causes reflex tachycardia. So you want to set hold parameters that, don't give this if the patient's heart rate is greater than 100. And this is very important in patients who have AFib. Another adjunct you can use to treat blood pressure is labetalol. Labetalol is an alpha and beta blocker. So a common starting dose is 10 milligrams IV every 4 hours, PRN as well, for SBP greater than 160 or 170. But remember, it's a beta blocker, so you want to make sure that you're not giving this if the patient is bradycardic. So I'll set a hold parameter for heart rate less than 6. Patients who take anticoagulants or antiplatelets. Next is pulmonary. So again, pulmonary surgical patients, they need incentive spirometry at the bedside. So incentive spirometry, remember, this is something they inhale through, and you want to educate them how to use it. Generally, we will tell them to take about 10 inhales per hour, or another common way to tell them to do it is every commercial break. But it's very important as this minimizes their chances of getting atelectasis. Again, nasal cannulas. Patients with common admission order sets will have nasal cannulas, but you want to wean them off of these, off to room air as soon as possible. And usually anything greater than 92% is acceptable. So then there's chest tubes. So in surgery, you're going to encounter chest tubes a lot. And so you have to know how it works and also how to troubleshoot them. When a chest tube is inserted, usually it's put on something called wall suction, and the maximum pressure you should check on the atrium should say -20. It should not be more than that. And then general algorithm is when it's on wall suction, you keep it on there for 24 hours and you measure the output. If after 24 hours, the output, usually this is the thing about surgery, it can be very surgeon or attending preference for these numbers, but oftentimes they'll say if the chest tube, a safe number is less than 200, for example. If it's less than 200 for 24 hours and there's no air leak, meaning when you look in the bottom left corner where the blue liquid is, if you don't see any air bubbles, then this is a good sign that an adequate amount of fluid has been evacuated and that there's no more air left. And so at that point, your attending or your senior may say, take it off wall suction and put it on water seal. At that point, now the chest tube is no longer connected to the wall suction and it's basically draining to gravity. You'll leave that for another 24 hours. And if the output is also less than 200 that next day and there's no air leak, then your team may tell you to remove the chest tube. And remember, when you're removing the chest tube, a common dressing you can use is some zero form petroleum gauze with 4x4s and silk tape, and you want to put it on their chest and cover it. Make sure you cut out the sutures ahead of time. And there's different ways to do this, but the way I tell them to do it is to take in a deep breath, hold their breath, and as I'm pulling out the tube, I seal it. And then that dressing stays on for about 3 days. In 72 hours, that chest tube hole completely involutes and heals. Remember that what I was just telling you is for patients who have come in with a pneumothorax. Hemothoraxes are different. So hemothoraxes, there's blood in the chest. So we're generally much more conservative with when we pull the chest tube in hemothoraces, because you want to make sure all the blood is evacuated, because anytime there's a retained hemothorax, that can form scar tissue. It's also a nidus for infection. It can form an empyema, or it can cause, a fibrothorax. So in the cases of a hemothorax, we generally want there to be pretty much zero blood output from the chest tube before we pull it. If there is any problems with draining the hemothorax, or there's concern that the chest tube isn't working, ways to troubleshoot it is to inject TPA into the chest tube to break up the clots. Or if that isn't still working, and after about 5 to 7 days, within a week, then the patient may need to go to the OR for a VATS to wash out and evacuate the blood under surgery. When you pull out a chest tube, remember to order a post-pull chest x-ray. You can order the chest x-ray 4 hours after you've pulled it to evaluate, to make sure that there's no new pneumothoraces. So on the floor, especially for trauma patients too, you'll see patients who have tracheostomies in place. Tracheostomies are generally placed when a patient has been intubated for longer than 7 days, or if they have been foreseen that they will be intubated for longer than 7 days, then your team may place a tracheostomy for the patient. And the tracheostomy basically is more sanitary. There's less risk for infection. There's less days on the vent, and it's also more comfortable for the patient as it has a wider diameter and less length to take in oxygen. You should learn common terminology. So, the tracheostomy tube usually starts at 8 millimeters. So you should be aware of certain terminology like ATC. So ATC is an aerosolized trach collar. It's basically blowing aerosolized air through the trach. And then this is a patient that usually the first step when they're disconnected from the vent. Then you'll also hear about something called PMV trials. So PMV is passive mirror valve, and it's basically a valve, a one-way valve that goes over the trach and caps it, but it allows for them to breathe through the trach. But when they're speaking, none of the air comes out of the trach, and it only comes out of their mouth, which allows them to push air through their vocal cords and phonate. Remember, when the tracheostomy is open to ATC, they cannot generate enough air through their vocal cords to make sound. So when you cap this, then they can breathe through it and then also be able to speak. Then there's the next one, which is called capping trials. So when you're trying to wean someone off a tracheostomy collar and to decannulate, which means remove it completely, the next step you'll see is there will be something called capping trials, where they will place cap, which can be the respiratory therapist or the speech therapist will place a cap over the tracheostomy to simulate as if they can speak through their airway independent of a trach. The most important thing when you're capping a patient is to remember that these tracheostomy tubes have a cuff, a balloon cuff. And so that cuff has to be completely down so that when this is capped, that they have access to breathing. Because if that balloon is up and you've capped it and that balloon is completely open, there is no way for them to breathe through their nose or mouth because the balloon is in the way, and you're essentially suffocating the patient. So anytime you're doing capping, or even PMV trials for that matter, you want to make sure that the balloon is completely down. This is very important. And then finally, If they're tolerating their capping trials for 24 hours continuously, then you can decannulate, which means you'll remove the tracheostomy tube completely. There will be a hole there, and you basically cover it just like similar to a chest tube, and then that tract will close on its own. Patients will also come in with rib fractures. Remember, with rib fractures, patients will have decreased minute ventilation due to decreased tidal volumes, and they'll also be tachypnic from the pain. So the standard treatment for rib fractures is two things: good oxygenation and pain control. You want to make sure they have good enough pain control so they can breathe through that chest pain from the broken ribs, and you're making sure that their oxygen levels are titrated adequately. As an intern, if a patient on the floor is desaturating, meaning that their oxygen saturations are changed from baseline, COPD patient may be 88% at baseline and there's no change, I wouldn't necessarily call my senior for that. But if someone usually saturating at 100% is now suddenly 88% with increased oxygen requirements, 6 liters of nasal cannula, and they're still saturating below 90, this is something you definitely need to call your senior immediately, because this is often an ominous sign. But when you go there, make sure that you're thinking about the things you need to order and to get a workup ahead of time. And then you want to lay eyes on the patient, make sure their head of the bed is elevated, that they're able to protect their airway. If there's secretions, you want to get a Yankauer and suction out their mouth, get rid of the copious secretions ahead of time. You want to turn up the nasal cannula, or if that's not working, then ask the nurses on the floor for other adjuncts like a non-rebreather or a high-flow nasal cannula to temporize the patient and maintain their saturations until someone more senior is able to assist, or before they need to go down to the ICU. So these are totally things that you can be doing ahead of time to protect the patient. If no one comes soon enough and the patient continues to desat, then you can call a rapid response. Next is GI. So in a surgical patient, anytime a patient has abdominal pain that is new, you want to do a physical exam, talk to them, but then a safe thing you can order is a KUB, kidney, ureter, bladder, which is also known as an abdominal x-ray. And this will help give you, assess to see if they're having an ileus or a small bowel obstruction, or to even rule out free air. Patients who are on narcotics, make sure they're on a good bowel regimen to minimize constipations. At our institution, we use Colace and Senna prophylactically, and if they're still having problems, other adjuncts you can use are Miralax, 17 milligrams BID. You can also use Lactulose. You can also be wary, but a lot of times, if nothing's working, my last line is mag citrate, and mag citrate works very well. You can also go from below, Dulcolax suppositories, 10 milligrams, or you can do Fleet's enemas. These are all adjuncts if the patient is still having constipation. Again, rule out a lot of these elderly patients, they may have hardened stool or calcified stool near their rectum, and if it's completely occluding their rectum, then they may also benefit from a manual disimpact. Again, a patient who has persistent diarrhea with history of antibiotic use and leukocytosis, you want to rule out C. diff infection and send it for a stool analysis. If a patient has nausea and vomiting, again, find out why they are vomiting. See the patient. Is it a small bowel obstruction? Is it ileus? Was it because of the adverse effect to narcotics? Make sure anytime someone is having nausea and vomiting, change them to NPO status, get an abdominal x-ray, and then give Zofran. If Zofran doesn't work, another second line that you can use is Phenergan. Surgical patients are high risk for ileus and small bowel obstruction. So anytime, things that you can do to help minimize the risk is make sure your electrolytes are in check. So you want to make sure that the magnesium is above 2 and the potassium is above 4. Low magnesium and low potassium increases the risk of ileus by decreasing peristalsis. If there's very high risk for vomiting or aspiration, then you can also go ahead and put the NG tube in as well. and put it to low intermittent wall suction. In terms of potential diagnosis of small bowel obstruction, you want to look at the white count. Is there leukocytosis? Do they have a lactic acidosis? Look at their vitals. Are they starting to look septic? If on the physical exam they're peritonitic with rebound peritonitis, then they may need to go to the OR. Remember, placement of an NG tube. A lot of times the nurses will place it, but you need to yourself know how to place it as well. So I encourage you in your intern year to learn how to place it. You want to place proper measurement is to take the tip of the tube and measure it from the tip of your nose to the earlobe and then down about 5 centimeters below the xiphoid. When you place the tube, you want to place it on that horizontal axis and not up towards the brain. You want to progress anteriorly to posteriorly. It helps if the patient tucks their chin in and they're taking small sips of water from the straw as you're advancing the tube. Don't forget to put lubricant on the tube, heat it up, make sure that it's pliable, and as you advance it, make sure that it's not in their airway. You can check if it's in their airway, they'll start coughing a lot and they'll also start to desat. That's when you take it back out. If it's properly in, they won't be coughing, their saturations will be good. You can always auscultate it at the stomach as well. After it's in, before you do anything, you get a KUB, make sure that it's in the stomach, and then at that point, you can put it to wall suction. You also need to know how to troubleshoot an NG tube that's not working. A lot of times, I'm gonna post a picture here, but the NG tube, the duo tube, will have a blue sump, right, that goes to the air, and then the white main tube is the one that actually suctions out the contents. A lot of times when there's no output, the two most common is that the tube is actually pressed up against the mucosa of the stomach, so it helps to advance or retract the tube plus or minus 1 centimeters and twist it until you see suction coming out. Try to get it off the wall. If that doesn't work too, another thing that you can do is actually, the blue sump is actually an air vent, so it actually pulls in atmospheric air through the tube to minimize the amount of pressure that's suctioning in, and it's actually kind of like a safety mechanism. But you can actually flush the blue tube with a 60 milliliter syringe. It's also called a piston syringe or a Toomey syringe, and you can slowly flush air into that to try and open up and flush out any particles. Also, you can untwist the main chamber clear tube from the wall suction and slowly flush sterile water into there as well to try and flush out any particles that may have gotten stuck in the tubing. And if the tube is properly working, then you should be able to hear air being pulled through the blue air sump. Fluid, electrolytes, and nutrition. So again, anytime someone is pre-operative, you want to make sure they're NPO after midnight, and anytime they're NPO, they should have maintenance fluids running, which is their weight in kilograms plus 40, except in the cases of CHF or chronic kidney disease, then you want to be more conservative with your maintenance rate, and usually half maintenance rate is a good starting point. Your pre-operative fluids of choice are usually normal saline, or something at our institution we use as Plasmolite, which is like a physiologic IV fluid solution. Another one they call the surgical fluid is D5 half normal saline with 20 milliequivalents of potassium. Some institutions, they don't use weight-based, they also eyeball and use kind of estimations. If you want to do estimations, usually the small elderly or frail patients usually get about 75 cc's an hour. Normal habitus is usually 100 to 125 an hour, and if they're obese or larger, it's usually 150 an hour. After someone is post-op, you want to advance their diet per recommendation of the surgeon. Remember, it can be clears, it can be fulls, it can be regular diet. Clarify beforehand, and then once they're on a diet, you want to turn down their maintenance fluid to something called KVO, which stands for keep vein open, and the maintenance fluid rate usually drops to about 10 or 20 cc's per hour, which is negligible, but that helps you maintain peripheral IV access by keeping the vein patent in case you need access later. Electrolytes. A lot of times at the hospitals, most institutions now, there's an electrolyte replacement protocol, but certain things you should keep in mind in the back of your head is potassium. Usually for every 10 milliequivalents of potassium that you give, that will increase your potassium by 0.1. So if you want to increase your potassium by 0.4, then you can give 40 milliequivalents of potassium. Magnesium is usually replaced like 1 gram or 2 grams, and you want to try to get your magnesium above 2 milliequivalents. And then, but usually at most hospitals now it's per protocol, but it helps if your protocol is a very conservative amount of replacement. So say you want your potassium above 4 and the hospital will only replace it to 3.7, then you can give the extra 40 milliequivalents on top to hit your target of 4. And then remember the downsides of each commonly used maintenance fluid. So, Plasmolite has less sodium milliequivalents per liter. So if you give too much of it, it can predispose to hyponatremia. Normal saline can actually predispose you to non-anion gap metabolic acidosis, and lactated ringers contains bicarb, but it also contains calcium and potassium, so it can predispose to metabolic alkalosis, but can also give you hyperkalemia, hypercalcemia. As a general rule of thumb though, usually you have to think about what kind of fluid to give. So if someone is vomiting a lot, then they're going to get hypochloremic, hypokalemic, metabolic alkalosis. So you wouldn't want to give them more bicarb. So LR would be, the wrong choice for vomiting, right? So you would give normal saline, for example. But if someone has, constant enteric losses from enterocutaneous fistula, or they're having a lot of, if they have a bile leak, these things contain a lot of bicarb in them. So with fistulas or ileostomies, when you're losing all that bicarb, a good replacement would be LR. LR is also good for burn patients as well. Next is you're commonly going to see hyponatremia. So you need to know how to treat hyponatremia and work up what the cause is. So the first thing you have to ask yourself, is this acute or chronic hyponatremia? Chronic hyponatremia, you want to be really careful about changing it too fast. If you overcorrect hyponatremia too fast, you can cause central pontine myelinolysis, and if you correct hypernatremia too fast, you can cause cerebral edema. In the acute changes of sodium, those types of consequences are less likely, but you want to first assess the chronicity of it, and then the next thing you want to do is check for tonicity. Is it hypertonic, isotonic, or hypotonic hyponatremia? Right, hypertonic, normal serum osm is usually 275 to 295. If it's above 295, oftentimes this is secondary to hyperglycemia, so correcting glucose. If it's isotonic, so between 270 to 295, it's usually due to hyperproteinemia or hyperlipidemia, which is known as pseudo-hyponatremia. The majority of them will fall under the hypotonic category, so less than 275. When you've determined that the serum osm is hypotonic, then you can then subdivide it into fluid status. Are they fluid overloaded? Are they euvolemic? Or are they hypovolemic? And from there, you can start differentiating. Hypervolemic would be from like CHF or over-resuscitation. Isotonic, common ones are primary polydipsia or SIADH. Hypovolemic, a lot of times it's from overdiuresis or nausea or vomiting or diarrhea. So once you have the causes and your differentials are narrowed, then it can start tailoring your treatment. Other things you can do too is work up a FeNA, fractional excretion of sodium, which basically will determine, if it's greater than 2, then it's probably intrinsic renal failure, ATN, or if it's less than 1, then it's probably pre-renal azotemia, so they need fluid. If it's very low, usually for us, the threshold is anything below 125. That's starting to be ICU territory. While you're waiting, and if you don't have a clear diagnosis yet, first you want to treat the underlying cause, but adjuncts to correcting hyponatremia, first you can give normal saline and see what happens, if that makes it better or worse. And if that doesn't work, you can always give 2% normal saline too. 2% normally saline, we usually go slower, like 30 mils an hour, but then we do serial sodium checks to make sure we're not overcompensating. Q4-hour sodium checks is adequate. You can also give, the textbooks don't really talk about this too, but in practice people will give salt tablets too with their food, and then that can help increase your sodium levels. And then but if you've done the workup and it's primary polydipsia or SIADH, then the treatment for those is fluid restriction, usually limiting them to less than 1 liter per day of free water. And then you want to make sure you correct the sodium less than 10 milliequivalents per day to minimize the risk of central pontine myelinolysis and cerebral edema. Again, when you're restarting diets, hospitals will generally have different types of regular diets. So you want to look at your patient's comorbidity. If they have cardiac conditions, comorbidities, then you can restart cardiac diet. If they have ESRD, then you can start them on a renal diet. If they're diabetic, you can restart them on a diabetic diet. If you're about to advance the diet, again, check to see what the operating surgeon you're attending's recommendations are, if they should be advancing right away or not. A good time to ask is at the end of the case in the operating room. And then also when you're restarting a diet, especially the elderly patients, you want to make sure there isn't any contraindications for feeding. Maybe they have an aspiration risk or a weak swallow, and you want to rule those out before you advance their diet. Oftentimes too, when you're getting an H&P or taking a consult, I'll ask the patient, what do you eat at baseline? Can you tolerate a regular diet? And that helps smoothen out their hospital course. If there's any concern for aspiration or dysphagia, you make the patient NPO, elevate the head of the bed, and then you can also get speech therapy to conduct a swallow evaluation. And then at our hospital, we usually make patients preoperatively NPO except for medications. So they are NPO, but they can take their PO meds with small sips of water. So this is what I'm talking about. Like when you're in medical school or reading the textbook, there's different types of tubes and they have different types of names. So a Dobhoff tube is a very low diameter tube and it's used for feeding only, or it can also be post-pyloric, but you cannot suction from a Dobhoff tube. It's for feeding only. When you're giving these feeds, they can be given continuous or they can be given boluses. Boluses are generally more physiologic, which is preferred, but we only start patients on bolus tube feeds once they have had return of bowel function, they're passing bowel movements, then we will switch them to bolus feeds. Beware though, when you're switching to bolus feeds, you should know where the tip of the tube is terminating at, because if it is a post-pyloric tube and it is in the duodenum or the jejunum, then if you're giving bolus feeds through that, you can cause perforation of the small bowel. Remember, that's a contraindication. You can only do bolus feeds if it is intragastric. Next, renal. We usually hold ACE inhibitors and angiotensin receptor blockers perioperatively. Postoperatively, from anesthesia, patients may have weak detrusor muscles, so they may be predisposed to having urinary incontinence beforehand. So it's very important to do void checks. So remembering that after anesthesia, they may have difficulty voiding. So what we usually do is we do bladder scans if they're unable to void after 6 hours, and we'll check it, and anything usually over 400 cc's is getting to that point where you can cause nerve damage to the bladder. So if it's over 400, then we'll do something called the intermittent catheterization. So you place a Foley catheter in to decompress them and then remove it. And you give time for them to try and encourage them to void on their own. and ambulation can help with that by putting gravity on their bowels. If they don't void again, you check again after 6 hours. And if usually about 3 times if they've required something called straight catheterization, which is the fully in and out 3 times, and that usually buys them a fully catheter. Again, there's also adjuncts you can give with urinary retention. If this is no longer due to anesthesia, you have to check the underlying cause. Is it BPH? You can start them on Flomax or Cardura, which is also an alpha-1 blocker. If it's from a weak detrusor muscle, which is from overflow incontinence, then you can give Befanacal, which is a muscarinic agonist, which gives the bladder a squeeze. If it's from urge incontinence, so overactive detrusor muscle, then you can calm down the detrusor by giving oxybutynin. Hemonc. Post-surgical patients, we worry about bleeding. So when do you give packed red blood cells? You usually give packed red blood cells at a hemoglobin level less than 7. That's usually an indication to replace blood. If they're a cardiac patient, then we like to keep the hemoglobin level above 8. Again, surgical patients are at the highest risk for DVTs and pulmonary embolisms, as well as trauma patients. So they should always have DVT chemical prophylaxis. Usually what we use is Lovenox, and it's weight-based. So average person would be Lovenox 30 milligrams subcutaneous Q12 hours. If they have a low GFR or have chronic kidney failure or end-stage renal disease, would give heparin instead, sub-Q, and it's usually 5,000 sub-Q every 8 hours. If a patient presents to you as a trauma patient and they're on therapeutic anticoagulants or antiplatelets, then you need to know the reversals. So first, you want to order the lab, PTT, INR, PT, depends on your institution, but you may have a TEG as well, thromboelastography. The fastest reversal for a 10A blocker like rivaroxaban, which is known as Xarelto, or Eliquis, which is apixaban, you can give prothrombin complex concentrate, PCC. Also, for the fastest reversal for warfarin or Coumadin is also PCC. And then if it's warfarin, but it's, doesn't need to be corrected right away, if their INR is super therapeutic, but they're not bleeding, or if they don't have a traumatic brain injury, then you can also reverse with fresh frozen plasma and 10 milligrams of vitamin K. The fastest reversal for antiplatelets like aspirin or Plavix, you want to replace them with platelets. And the way we do it at our institution is to check the TEG, and usually we want a AA inhibition, aspirin inhibition of less than 50%. Always beware of HIT when you're starting patients on heparin. Usually a drop of more than 50% in 24 hours. You should be concerned for HIT and send out your serotonin release assay and antiplatelet factor 4 labs. Generally, general surgery patients preoperatively should have platelets above 50,000. If it's neurosurgical, then above 100,000. In surgery, our INR target is usually less than 1.5, which is acceptable for surgery. Again, when you order 1 unit of platelets, so 1 platelet pheresis, it usually actually has 6 packs of platelets in it. And so 1 packet will raise your platelet approximately 5,000. So if you order, you have to check at your institution what 1 platelet pheresis means, because is that 1 pack of platelets or is that 6? And then usually if it's the standard 1 platelet pheresis, which is 6 times 5K, so 1 platelet pheresis should usually increase your platelet count by 30,000. And then another rule of thumb is 1 pack of red blood cells will increase your hemoglobin by 1. ID, infectious diseases. Commit to your memory of the 5 W's: wind, water, wound, walking, wonder drugs. And usually my way to remember it is at days 1, 3, 5, 7, and 9. So again, you've learned this in medical school, so I won't go into too much of it, but anytime a patient is spiking fevers, usually on the first day, then it's atelectasis, so you encourage them to continue with their incentive spirometry exercises and you monitor them. By the third day, you want to think about UTI, look at their urine, maybe send a urine analysis. And then you want to look at their wounds at day 5 and make sure that the wounds look good, but you should be looking at this all the time. And then you want to check for DVT. Are they having any swelling or pain in their legs? Have they been missing their doses of their DVT prophylaxis? Are they ambulating? If not, then you might get a DVT ultrasound of their lower extremities. Patients who have a Foley catheter post-operatively, you want to remove it as soon as possible to minimize the risk of UTI. Common antibiotics that you should commit to memory that we use in surgery a lot are Zosyn, 3.375 IV Q6 hours. We also use vancomycin a lot, which is weight-based, about 15 mg per kg. And then the pharmacy will titrate it based on the peaks and troughs. We use Cipro a lot, Flagyl a lot, which is metronidazole. We use Augmentin PO a lot for when we discharge them, usually 875/125 milligrams every 12 hours. And then we also use Ancef perioperatively. That's usually 2 grams IV once before incision. We also use it for fractures too, open fractures. So we give 2 grams of IV Ancef every 8 hours for the open fractures and up to 24 hours after it's closed. And then we also use clindamycin before incision as well for patients who have allergies to Ancef. So then you can use clindamycin 900 milligrams once. But those are the common ones that you should try to commit to memory. Endocrine depends on the institution, but pre-surgical patients, we usually hold their diabetic medications inpatient until they're about 48 to 72 hours post-op. So we'll hold the newer medications like Januvia, or we also will hold metformin for the risk of lactic acidosis, and we'll have them on insulin sliding scale. If their hyperglycemia is uncontrolled, then we may consider restarting that, or we may restart them on a long-acting insulin like Lantus, but that's usually when they've been stable post-operatively and they are unlikely to go back to the OR. But that's very institutional dependent. Usually if they're NPO preoperatively, we do glucose checks scheduled every 4 to 6 hours around the clock and give them sliding scale around the clock. If they are on a diet, then that changes. Once they're regularly eating, then we just check their glucose levels before and after meals. Again, what is your target glucose level for inpatient? And there was a trial called the NICE sugar trial, which showed that the optimal blood glucose levels is somewhere between 140 to 180, which has the lowest risk of mortality. If they are hypoglycemic, so anything less than 70, and they are symptomatic, if they're tolerating PO, what you can do is give them something to drink, like orange juice. And if they're NPO, then you can give them IV D50 dextrose shots. Musculoskeletal. Whenever you have a patient who has fractures, when you're examining them, it's very important to check for their pulses, making sure that they're getting good perfusion. You want to rule out compartment syndrome, especially in tibia fractures or tibial plateau fractures. If they have increasing pain out of proportion, remember the 6 Ps, you want to always rule that out. But the first sign is increasing pain out of proportion, and the last sign is loss of pulses. But anytime I'm checking, post-operative patients who have had a ORIF of, their lower extremities, I want to check sensation, motor control, I want to check their compartments, and I want to check their pulses. And then I look at their dressings. Usually you should check, because if ortho is the one who's operating and you're taking care of that patient, you want to check their notes to find out what their weight-bearing status is. Skin and wounds. So usually, for X-laps, our staples will stay in until post-op day 14. Same with any sutures that are from the head down. If it's sutures in cosmetic areas like the face, we usually can take that out by day 7. Patients will have rashes in the perineum. A lot of times it's from contact dermatitis, or like a diaper rash, then you can use zinc oxide. But you should also rule out the possibility of a fungus. and in that case you can order them meconazole cream or powder. Ways to tell if it's fungal is looking for symmetry in the folds and also looking for peripheral satellite lesions. Make sure your patients, if they're bedridden, that the nurses are turning them frequently to minimize the risk of decubitus ulcer formation. If it's a infected or necrotic looking wound, then we usually, after debridement, will treat it with wet to dry dressing changes. And the wet to dry, what that does is it helps basically not only absorb out the bacteria and the necrotic material, but it allows it so that when it dries, you want it to dry just enough so that when you're doing the dressing change, it's dry enough that it's basically it's producing micro debridement. It's peeling off the very superficial layer of necrotic skin without taking off too much that it causes trauma or bleeding. If you place a dry dressing on a wound bed, then you basically increase the risk of the dressing fusing with the wound, and when you take it off, you're basically causing trauma or bleeding. But if the wound is very soupy or very wet, then a wet to dry dressing might make the wound too wet. So the idea is you want to have the right amount of moisture. If it's completely dry wound, like a scab or anything that is not super saturated, then applying, topical bacitracin or Vaseline over the wound to keep it moist will accelerate wound healing. Other things though is if the tissue is clean, it's not infected, it's starting to granulate, another option is to use a wound vac, which helps minimize the amount of serous exudate that is produced, but it also helps accelerate granulation. Anytime someone has an abscess that is drained, we usually will pack it with iodoform or plain packing strips, which is like gauze but in the form of a ribbon. It comes with different diameters, 1/4 inch, 1/2 inch, or 1 inch, and you basically want to pack that every day. You can use a cotton tip applicator and pack the wound to the base and instruct the patient to do these dressing changes every day. And what happens is each day the pocket will become more and more shallow until they can no longer pack it anymore. Another thing that you want to learn is how to do wound vac changes as an intern and be proficient at doing it and being able to change it on the floor. And then lastly is sign out. When you're signing out to the night team, you want to be efficient in your sign out, but you also want to tell them what their tasks are for the night, if there's anything to do and things to look out for, things that you're concerned about that may happen, and you preemptively solve the problem for them. So for example, patient A is a 79-year-old female who has soft blood pressures. This is her baseline. She's usually systolic 95s. So if she's in that range, don't be alarmed. She responds very well to 500 cc fluid boluses. You want to give them things to look out for. Patient B, we've been treating her with AFib RVR today. She is rate controlled at this time, but if she does become tachycardic again and in RVR, she responds very well to 2 doses of 5 milligrams metoprolol. Patient C was having nausea and vomiting today. We placed an NG tube to low intermittent suction. There's a abdominal x-ray to follow up on. We also ordered lactic acid that you need to follow up on tonight. So when you're doing the sign outs, think about what tasks do you want them to follow up on or execute, and patients you're worried about, what they should look out for, but not only what to look out for, but give them a first line treatment for them to go off of so that they have something to work with and then they can go from there. Congratulations again for getting into residency. It's a big moment of your lives. The only advice I can give to you is to remember that it's a privilege to be a resident. And number one, work hard and be honest. Care about your patients. Caring is 50% of the thing. If you care about your patients and you care about your service, this will serve you well. Look out for your fellow residents and think of each other as a unit, as a team, and you're looking out for each other. And especially as an intern, Always err on the side of caution. If there's something you're unsure about, don't be afraid to ask. Your senior residents were interns themselves, as was I. This is why I'm making this video in the first place, because I remember what it was like to be in your shoes, and I remember being afraid to ask questions sometimes, but just don't be afraid. Communicate, work hard, and every day you'll start to realize that you're learning more and more whether you know it or not. And by the time July hits and you're a second year resident and there's a new batch of interns and you're showing them the ropes, you'll realize how much you learned. Again, work hard, play hard, have fun, and we'll see you in the next one. All the best.